key thing here is that it was discovered that when you have gene amplification of HER2, you get a resultant overexpression of that HER protein. And that overexpression leads to a driver for certain cancers. So when you have an overexpression of HER2, it leads to the cancer being more aggressive.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Rowena Schwartz, Professor of Pharmacy Practice at the James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, about her inhibitor drug class. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome. Thanks for joining us today, Mo.
Thanks for having me.
So to start off today, can you give us a brief overview of the history of the HER inhibitors in this field of oncology?
I certainly can. And this is one of my favorite things to talk about. And this one I particularly find fascinating because I sort of saw it develop in practice. So I think to start before you in my practice, in the early 1960s, Stanley Cohen discovered the protein EGFR. And it was discovered that this EGFR, when it binds the EGFR receptor, that had an impact on cell growth. HER2 is a protein that was identified in the 1980s, and it actually was very similar to this epidermal growth factor receptor, and it was found that they were part of a family. So HER1 is EGFR, HER2, HER3, HER4, that's part of the family. There is a lot of similarities between these proteins, though they're not exactly alike. The key thing is that when stimulated, that these proteins dimerize, meaning come together. So think 1 + 1. So you can either get homodimerization with HER2, so HER2 dimerizing with another HER2 protein, or you can get heterodimerization, HER2 with HER1 or HER3 or HER4. The reason I'm going through that is because it's really important when we talk about the different drugs. A key thing about this protein is that the HER receptor contains an extracellular ligand binding domain, meaning outside the cell. Then it has a transmembrane domain, and then it has an intracellular tyrosine kinase domain. And that's important because we're going to talk about monoclonal antibodies that bind to the extracellular domain. And we're going to talk about tyrosine kinase inhibitors that are important with the intracellular tyrosine kinase domain. So key thing here is that it was discovered that when you have gene amplification of HER2, you get a resultant overexpression of that HER protein. And that overexpression leads to a driver for certain cancers. So when you have an overexpression of HER2, it leads to the cancer being more aggressive. In fact, when we first started talking about HER2 positive breast cancer, the key thing is if we look at just the disease, not disease and treatment, that the patients that have HER2 positive breast cancers, they tended to be more aggressive because you had those drivers. So that becomes really important when we talk about where the drugs fit in practice. And that's a little bit of like an overview of HER protein. And then in terms of the inhibitors, we have, because of science and the evolution of science, there's been development of monoclonal antibodies to target that HER protein. There are antibody drug conjugates that use a monoclonal antibody to target it, but then deliver a payload, which is a chemotherapy. We have tyrosine kinase inhibitors that target HER2. In fact, a lot of them target more than just HER2. And then just end of November, we just had approved a bispecific antibody, not a bispecific T-cell engager, but a bispecific antibody that targets two epitopes of the HER2 receptor. That was approved for biliary tract cancer.
Well, we're only one question in. I've already learned like 4 or 5 things. So this is going to be great. Thank you for that really comprehensive overview, not only of just the protein itself, but kind of how that translated into some of the therapies that we are maybe familiar with already, or sounds like there's new ones that we're going to become familiar with. So exciting to have that as our foundation for the rest of our conversation today. So let's talk a little bit about the mechanism of action that we see with HER inhibitors.
Just as I mentioned, let's go through the different kind of types. So we have monoclonal antibodies. Some people call them naked antibodies now because they're not hooked to anything. And the classic is trastuzumab. It binds to the extracellular domain of HER and prevents that homodimerization. This in turn turns off the downstream signaling to the cancer cell and causes cancer cell arrest, and actually leads to antibody-dependent cellular cytotoxicity. Pertuzumab is also a naked antibody, but it binds to a different part of the extracellular domain. It prevents heterodimerization. So where trastuzumab prevents HER2, this prevents HER2 and HER1, HER2 and HER3, HER2 and HER4 dimerization. And then that leads to downstream effects that causes cell arrest and leads to the benefit of inhibition. There is also another naked antibody, and I always want to mispronounce it because when I look at it, I see the name Margaret, and that's not it. It's margetuximab. Really interesting thing about this, which I think is a big lesson to come out of this with. This is a antibody that was engineered so that the FC domain increased its activity for ADC. So basically what that's saying is that they took an antibody and they changed it, which we know that that can be done, to make it even better in terms of causing cell death. Now those are your naked antibodies, and they're still used singly and in combination. The antibody drug conjugates, these are some of the first most of us are familiar with. They're antibodies, trastuzumab, linked to a payload. And in the cases that we will talk about with adotrastuzumab and Tanzine, or the FAM trastuzumab deruxtecan, they are hooked to a chemotherapeutic agent. So it's a way to deliver that chemotherapy directly to the HER2 targeted cell. Key thing here is that we've learned is that sometimes that drug, when it's released from the antibody, can be released from the cell and can hit cells around the cancer cell that overexpresses HER2. So that's called the innocent bystander effect. So we're learning a lot more about antibody drug conjugates. The tyrosine kinase inhibitors, they're interesting in that they're these small molecules, just like we know about other tyrosine kinase inhibitors, that target intracellular catalytic kinase domain of HER2, so the internal part. Key thing is we have a number of different tyrosine kinase inhibitors, and they target different parts of that family. So lenvatinib inhibits EGFR, or HER1 and HER2, whereas neratinib inhibits EGFR, HER2, and HER4. So they have different targets, and that's really important. And the last one, just to mention, is the bispecific, like I said, that actually targets two different epitopes of HER2.
Again, learning so much with every answer that you give. It just helps to kind of connect all of those dots. We've heard a lot of these drugs for a long time. And so I think it is just important for us to always kind of revisit sort of what's underneath that? Like, where does this all start? And so I just always love these episodes of going back, digging through kind of the history and where things started and kind of helping to connect the dots. As you mentioned, there's new drugs already coming out that are related to the same class. And so it just, to me, it just helps things crystallize a little bit better. So thank you for that.
You're welcome.
So let's dig a little bit deeper. Talk about some of the primary subclasses of these HER2 inhibitors. And I know you've done so already, but let's highlight again some of those examples of both familiar and newer agents.
I think the monoclonal antibodies, the unconjugated or naked ones, are still really the foundation of practice in many diseases where we see HER2 overexpression. And of course, the best example is breast cancer. Key thing, though, is that this overexpression can happen in lots of other types of cancer. So using drugs such as trastuzumab in combination now with pertuzumab is something we see in breast cancer and maybe other diseases. In fact, we see it so much that there is now a combination product that's made that includes both of those agents at a fixed dose. The antibody drug conjugates, they really have changed how we look at treatment because we're seeing some efficacy in terms of specifically the FAM trastuzumab deruxtecan in patients that have what is called low HER2 positivity. So we always looked at these agents as being active in individuals that have cancers that overexpress HER2, that were HER2 positive, 3+. Now we're learning that in even people that have low expression, certain drugs such as these antibody drug conjugates can be very beneficial. The tyrosine kinase inhibitors, a lot of them were developed to hit targets differently and be effective when our monoclonal antibodies aren't. So when resistance develops, that's where these TKIs have kind of been developed to sit in practice. Will they stay there? That's hard to say. They're often combined with other chemotherapy, but that's where you'll see these used. The newest agent, like I said, end of November, I think it was like November 20th, it's called, and I got to be careful, zanidatamab. It binds adjacent HER2 molecules. What it does is cause HER2 disorganization, and it's different than what you see with trastuzumab or even trastuzumab and pertuzumab together. It also elicits a different immune response by eliciting a potent complement-dependent cytotoxicity or CDC. So that's pretty interesting. A little bit different mechanism. Always something important to look at. It inhibits cell signaling, cancer growth, and it was approved for adults with previously treated unresectable metastatic HER2 positive biliary tract cancer. So these agents, how we use them is really evolving, and we're seeing new agents be developed.
Well, and so now this might be a difficult question to answer because, as you've just described, the classes of these drugs and sort of their targets and how they interact are very different, even though they're all sort of targeting the same HER receptor or one of the HER receptors. Can you talk a little bit about some of the common toxicities or adverse events that we might see with these various HER inhibitors?
I think you're so on target. Well, you're right. It depends on what the target is, what kind of toxicity. And it also depends on what kind of agent it is. So when we think of those antibodies that target HER2, whether it be the antibody drug conjugates or whether it be the unconjugated trastuzumab, pertuzumab type, one of the biggest toxicity I think most of us think about is the cardiotoxicity. And the important thing about this cardiac toxicity, it's not the type of toxicity that we see with anthracyclines. But we do know that when you use these drugs with an anthracycline, it appears to increase that sensitivity to anthracycline-induced injury. So this is thought more to be a disruption of the protective function that HER2 has on the cardiac tissue. So with this toxicity, sometimes just holding the inhibitor, the monoclonal antibody, you'll see return of function. The other big toxicity that you're going to see, especially with these monoclonal antibodies, is infusion reactions. And there's been a lot of different strategies developed to kind of get around these infusion reactions. The TKIs, because many of them target EGFR, you're going to see some diarrhea. But depending on the agent, there are different toxicities and different boxed warnings. So lapatinib has a boxed warning for hepatotoxicity. Neratinib has a boxed warning for diarrhea. In fact, neratinib has such an issue with diarrhea that there is a prophylaxis regimen for the first couple of cycles of loperamine that's recommended. Package insert, easy to go look at. The antibody drug conjugates have some of the antibody toxicities. And then you have the toxicities of the chemotherapy that's linked to it. And then you see some of the things that we're seeing with antibody drug conjugates, such as interstitial lung disease. It's not common, this interstitial lung disease / pneumonitis, but it's really important. And so if you have a patient that has symptoms, you need to be aware. Some have hepatotoxicity, black box warning. They can cause hematologic toxicities and gastrointestinal toxicities because even though they're monoclonal antibodies, they're hooked to a chemotherapy agent. And so it depends on what the chemotherapy agent is, what kind of toxicity you're going to see.
So let's talk a little bit about how we manage the toxicities. Can you explain maybe a little bit about if there are pharmacologic strategies that we can use to either prevent or to help manage the side effects from these drugs?
For cardiotoxicity, the way that we tend to look at this is to take a look at patients prior to starting therapy, look at their ejection fraction, and then monitor routinely throughout their treatment. And I think most places that give these drugs have built in their order sets routine monitoring every 3 months so that they can make an assessment. And if there is a change in ejection fraction, that therapy can be held and or stopped. So that's one of the big things there. And then like treating it if it occurs. When you look at things like the diarrhea that you see with these TKIs, we manage them very much like we manage the epidermal growth factor receptor inhibitors, that we're very proactive with starting antidiarrheals, making sure patients are aware of this and making sure that they are taking fluids and things and letting us know if they happen. The infusion-related reactions are really interesting because one of the things we do with infusion-related reactions is if we're giving it in a IV formulation, we use those prolonged infusions for the first dose and then go faster with subsequent doses after we see how they tolerate. And then, of course, there's the development of these products that are given sub-Q that have less of the infusion-related reaction.
So what are some of the administration considerations that nurses should keep in mind when we're administering HER inhibitors?
So the thing that I think is most important, and I think this comes back to when we first got our first antibody drug conjugate, it is so important for people to know what specific drug they're administering, because so many of them have that trastuzumab name in their base that there was a lot of problems in the beginning with people thinking trastuzumab and the addo trastuzumab, when it didn't have the addo, they would get them mixed up. So knowing what drug that you're giving. The other thing now is because we do have these products that have hyaluronidase in the formulation so that they can be given sub-Q, it's important to realize if it's trastuzumab or if it's trastuzumab hyaluronidase, because there's a difference, like if you give it sub-Q or IV. So if you work with these all the time, you work in a breast cancer clinic or in a infusion suite that cares for a lot of patients with breast cancer, you know this. But then you go to where you have these drugs used in someone who has a gastric cancer or a lung cancer, who has HER2 positive disease. Most of us who don't live in the world of breast cancer don't know these nuances. So it's really important that if you're administering these drugs and they're not the drugs you're used to, you take a look at the difference with the product that you're using, and that if you have the colleagues or resources to kind of check what the best practices are in your institution, you reach out. Well, I don't work in breast cancer, but I got to tell you, I have a quick phone call to someone who I call every time I have a patient get one of these drugs. And I do see people get these drugs because of the diseases I treat. Those are some of the things I would think that are important when you're thinking about the administration of these agents.
As you've already pointed out, even if you know that your drug is a HER inhibitor, they come in all shapes and sizes. And so assuming that you know what that means, there's a risk that you might have the wrong sort of drug class in mind or sort of like the wrong target in mind. And so it's just, again, reading that package insert, consulting with your pharmacy colleagues, just as you said, phoning a friend if this is not your bread and butter, what you do all the time. Never assume that you know for sure. And if you're ever unsure, then make sure you're looking it up and understanding exactly what the drug is, how it works, and how it's supposed to be administered.
One of the things that I hear is people say about these antibody drug conjugates, which we use in all different diseases now. I hear so many people say these are not chemotherapy. And the thing of it is, they're chemotherapy. I think people like to say they're not chemotherapy because it makes people feel better that they're not getting chemotherapy. But the reality of it is that they are monoclonal antibodies linked to a chemotherapy. So some of the side effects that you get are related to the chemotherapy that's part of that conjugate. So I think people need to realize that, just like you said, you need to know what you're giving. And that antibody drug conjugate, when it's linked to chemotherapy, I'm going to call it a chemotherapy as well as a monoclonal antibody.
Well, that leads kind of to the next question. So what are some of these primary patient education points that we should be communicating with our patients and their caregivers about whatever variation of HER inhibitor that they're receiving?
It's funny because I think that one of the things as a healthcare provider that is important is understanding how these drugs work. I think that's pretty overwhelming to patients. When I say that, I think there's patients that probably know more of the science than I do because they're going to be online looking things up. So, I can't say that overall. But I think helping people understand what these drugs do, especially for the specific agent they're getting, and therefore what the side effects are for that agent, and helping them realize that don't look at the class, don't think of this as being trastuzumab. If it's trastuzumab, look at that toxicity. But if it is an antibody drug conjugate, look at that differently and helping them know what toxicity for what they're getting. The other education, I mean, those oral agents, they have toxicities that we have to make sure people are really aware of. Diarrhea, that's a big thing to make sure people know what to do when it happens. Certainly we can have them call, and I always recommend people calling because I'm like a helicopter person, want to manage everything myself. But you know what? I also want them to be able to self-manage when things happen until they get a hold of a healthcare provider.
Absolutely. I think back to your discussion of the cardiac toxicities, and I think that one's somewhat unique. I remember my experiences when educating patients about this. That sounds scary that it could impact the function of your heart, certainly a critical organ. So I think it's important to give them that reassurance of why we're checking that cardiac function, that ejection fraction, what those routine scans are for, what we're looking for, what will we do if we do see those numbers change. I think that one's a unique one that, again, patients may not feel it at, if there are slight changes happening that we can only catch by those repeat scans. It might not be something that they can feel, but certainly those are the things that we take ownership of watching and checking based on the results of those routine follow-up diagnostics. So I think that has been a unique one for me for those certain HER2 inhibitors that come with that toxicity risk.
It's funny. I'm sitting here. I wish you could see me because I'm like nodding my head. It's so funny. Like that's what I'm like. Yes, exactly. I agree. And the other thing I think is really important is when patients may go from, like a trastuzumab, pertuzumab, and then perhaps go to an antibody drug conjugate. I think it's important to make sure they understand that this antibody drug conjugate is different than what they've received before, and that they might have some unique side effects that was not something that we were as concerned about before. So I thought of that when you were talking. I think there's a big opportunity to help patients.
So how do you see pharmacists and oncology nurses collaborating to help manage these adverse events, these toxicities, provide the patient education, and really just serve as that trusted source of information for our patients who are receiving HER inhibitors?
We talk about this every time we talk, and I always think that it's really important for whatever practice setting you're in, that you establish who's going to do the education and how it's going to be backed up. I believe in a consistent message. So I think collaborating, because, in the best scenario, everybody's educating, but making sure that consistent message, making sure people get the same message is really important. I also think determining what the written information we're going to provide patients is so that it's consistent with what we're saying as well. And I think that's a collaborative discussion. I think that it's not, this is what we use. I just yesterday did a in-service about some drug therapy. And so before I did it, I talked to my team that works with me and said, would you include something different? And so that was to other professionals, but that's the same way it should be when we talk to patients. And I think it should be very coordinated, key efforts of not only what the toxicities are, but how we want them to manage and when we want them to call.
And, I really appreciate those comments and certainly agree of just the consistency so that whoever is talking with that patient and hearing their concerns or kind of coaching them through managing any adverse events that they're experiencing, they're getting the same information. And so you don't have to necessarily worry, oh, well, you talked to Nurse Susie last time, let me go grab her. No, I know the same information. I can provide that consistent reinforcement of what was told because we should all be telling them the same thing. And so I really appreciate that. Certainly, I think it can be challenging, especially when it comes to like written patient information and education. And where do we source those resources from? Are we all going to the same place? But I think your comments are absolutely spot on of just ensuring that there is a consistent approach and that everyone understands what tools and resources they should be using and just understanding the education points that we can reinforce to patients, whether we had them last treatment or not.
The other thing that I think is really important when I think about these new agents, I may not be the one seeing some of the stuff that happens when people are getting these new agents. I don't work in GI. I don't see biliary tract cancer. You can bet I'm going to ask my colleagues that work there. So I think the other thing that we don't talk enough about is that as individuals learn about these drugs from their clinical experiences, they share.
Absolutely.
I know that's where I read, but I love hearing from the practitioner who deals with it every day. What do you see? When I use these drugs in my practice, that's what helps me feel confident I'm giving really good care.
I love that. And I think certainly if you work at a large academic institution that has lots of subspecialty groups and you can kind of reach across the aisle internally, that's obviously a great option. But even for those that are working at maybe smaller community sites or satellite locations, and maybe you don't have that immediate connection with somebody in that specialty group, I think that's a great place where the ONS communities can fill that gap.
Yes.
Ask those questions to your peers. Very, very active discussions happening on the communities. And I see lots of conversations about, we're starting this new drug. What do you see? What do you do? How do you manage the logistics or the follow-up? And so I encourage all of our listeners to always consider asking some of these questions to the ONS communities, because you will get lots of feedback and input from your peers across the country. So Mo, what do you think the future looks like for her agents and their role in cancer care?
The fact that we just got this bispecific antibody says to me that we are going to see some of these great new strategies that we've seen in other diseases. It's going to happen with drugs targeting HER2. So there's definitely been publications about CAR T cells. There's really some interesting stuff about CAR NK cells that may be cancer vaccines targeting HER2. Lots of information out there. And there's data with bispecific T cell engagers as well. So I think the strategies that we are seeing, we have monoclonal antibodies, we've seen it go into antibody drug conjugates, which I think will just grow. And then some of the strategies that we've seen in other diseases will take hold. And there's definitely data out there that that's happening.
Certainly something to keep our eyes on. It sounds like we'll only continue to hear more about these types of agents, whether they're, as you mentioned, these sort of singular naked antibodies or combined with who knows what's yet to come. I think that these are certainly here to stay. Well, Mo, thank you so much, as always, for coming to the podcast today and sharing your wealth of knowledge. As I said, I learned something from the very first question. So this is a great episode, and I'm excited for everyone else to hear this and benefit from this great information as well. As we reach the end of our episode, we'd like to always run through a few quick fire questions to help summarize some of the important points that we've talked about. So to start that off, how do you think healthcare professionals should evaluate their hidden or their implicit bias when it comes to HER inhibitors?
I think that if you grew up when these were being developed, and I'm not talking my age, but if as these came, we tend to think of these drugs as all being trastuzumab.
Trastuzumab, yep.
And trastuzumab is a phenomenal drug. But other drugs have different mechanisms, work different ways. And it's really important not to, in your head, just think all HER2 inhibitors are trastuzumab. So I'm not taking a shot at trastuzumab at all. I just think that that's important as we are using these in practice.
Absolutely. What are some common misconceptions about HER inhibitors?
I think the one that people think is these are drugs for breast cancer. And, it's funny, if you go into the literature, that's where you get a lot of your data from. But these are drugs used in other diseases. And the fact that this bispecific just came out for biliary tract cancer shows that HER2 inhibition has a role in other diseases. If you go into the guidelines, that's certainly being indicated that if there's HER2 new overexpression, sorry, I go into my old talk, if HER2 overexpression, that may be a target that may be worthwhile, and guidelines help determine that. And the other common misconception, I think, is that people think all HER2 inhibitors cause cardiac toxicity. I'm not sure that we know that. We know the monoclonals do. Not as clear with the tyrosine kinase inhibitors. So again, toxicity is not the same across the board. Activity is not the same across the board. And where they're used is not just breast cancer.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think the resistance to HER2 inhibitors is essential. So just like we talk about resistance that happens to estrogen receptor antagonists, it's so important to realize that when you have this target and you have great drugs that hit the target, why do you get resistance? And there's lots of different mechanisms that are being looked at: incomplete inhibition of the HER2 receptor, HER2 mutations, which we're usually talking about overexpression, so that's different. Changes in that HER2 epitope that we're targeting, lots of things that have been thought to increase resistance. So learning more about that and realizing that's why when we have one drug going to another HER2 inhibitor may be beneficial, because how it works gets around the inhibition that may have occurred.
What additional training or education do oncology nurses need to stay current on this topic?
I think they need to know where to go to look up information for mutations. on specific diseases. So they need to go to, and I'm not plugging any place, but you need to know that if you have a patient that has colon cancer, you need to know where to go to look up if there's a mutation, if it's important. And you need to know where to get your information. So I've kind of gone past the point of you need to know the information. I think you need to understand foundations, which I think these podcasts do, but I think you need to know where to get additional information that will help you in practice.
What are some additional resources for patients and providers who want to learn more?
Now, this is my plug that I'm going to do because I think it's a phenomenal resource. The ONS Genomic and Precision Oncology Learning Library. I looked at it this morning because I had not had a chance to look at it when I was like pulling stuff together. I am amazed at the resources, not only the professional education tools, but the patient education tools. So it is one of the resources that I go to that, like in practice, I think that is a great resource. And then I always say the package insert is really helpful, and published guidelines are very helpful to find out where you use what drugs when.
Outstanding. Well, Mo, thank you again. Always a joy and pleasure to talk with you on the podcast. Do you have any final comments to share with our listeners today?
I think we've talked about most of the things I really think are important. I just think it's really important to continue to build your foundational understanding of these topics, even if you don't think it's going to impact your practice today, because from this comes more knowledge that you'll be better able to understand. So that's my encouragement, is just take every opportunity that you have to learn through whether it's ONS or other ways, because it will help you with all these new drugs that are being marketed.
Thanks so much, Mo.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.